Good evening, everybody. Should I say good morning, good afternoon, good evening, depending on which part of the world you're connecting from? But I think the majority of people on this session seem to be from India. So good evening and happy
Good evening,
Dussehra to
sir.
all of you.
Thank you, sir.
Good evening, sir. Thank you. I'm
It
joining
is-
from Toronto, so it's a good morning for me.
Oh, I see. Okay, good morning.
Yes.
So it gives me immense pleasure to introduce Dr. Vinita Sharan, who is a senior radiology consultant at Deep Tech Medical Services and an adjunct faculty at the Public Health Foundation. She has spent a good part of her career in San Beda College of Medicine in the Philippines. And what I'm proud to say is that she has been very active and is very responsible for organizing the virtual sessions in radiology for GAPIO. I must thank you, Dr. Vinita, for your consistent help and excellent sessions that you have organized and moderated in the past, and I wish that you continue to do so in the future. The topic is indeed something which is probably much more important as road traffic accidents and other aspects that cause trauma to the chest increase. And I'm sure that this session with its speakers would be invaluable to those who participate. With these few words, I'll hand over to Dr. Vinita and ask her to carry on with the session. Thank you.
Thank you, sir, for the kind introduction. And greetings of the day, everyone. Sorry. I think please mute, audience, please mute. So greetings of the day, everyone, wherever you are. And happy Dussehra to you. Thank you for joining us in the middle of the festivities. Welcome to the Radiology International Lecture Series organized by Global Association of Physicians of Indian Origin. For those who are joining us for the first time, I would like to introduce our president of GAPIO, Dr. Nandakumar Jairam, sir. You just heard him give the opening remarks. Dr. Nandakumar Jairam is the former chairman of Medica Synergie Group of Hospitals and an independent healthcare advisor. He is also the president of Rai Bahadur Arcot Narayan Swami Mudaliar Educational Charities in Bangalore. He's also the former chairman and CEO of Columbia Asia Group of Hospitals, and he has over 4 decades of experience as a surgeon in minimal invasive surgery. Thank you, sir, so much for your support for our radiology webinars. It's always very nice to have you on our webinar. Thank you. So at this point, I would like to request the audience to place their questions in the chat box below. We'll have a question and answer segment at the end of the 2 talks. So the topic for today is imaging and pitfalls in cardiothoracic trauma. And we have 2 renowned radiologists who will enlighten us on this topic. So we have Professor Atin Kumar, who will be talking about imaging in lung trauma. And we have Dr. Asutosh Sahu, who will talk about imaging in cardiothoracic vascular trauma. This topic is not only important for the practicing radiologists, but it is also very important and relevant for the cardiothoracic surgeons who actually take care of the cardiothoracic trauma patients. So we have with us Professor Subodh Kumar, who is Professor of Surgery in the Division of Trauma Surgery and Critical Care at Jayaprakash Narayan Apex Trauma Center, All India Institute of Medical Sciences, New Delhi. He is the chairperson for this session. Professor Subodh Kumar has joined as the Executive Director of National Board of Examinations in Medical Sciences in August 2024. He was instrumental in developing and starting various academic courses like MSc, NBEMS in trauma surgery, acute care, and critical care in the country. He has numerous fellowships, including FRCS, American College of Surgeons, American Association for the Surgery of Trauma, and he is the Vice President of the Indian Society of Trauma and Acute Care. He has published over 200 papers in international and national journals, including several book chapters. He is also the Associate Editor of Indian Journal of Surgery and Reviewer Editor for several peer-reviewed journals. He has secured more than 20 funded research projects as principal investigator and co-investigator. He has received AIIMS Excellence Research Award in Clinical Research category. I now invite Professor Subodh Kumar to share his thoughts and perspectives on cardiothoracic trauma, and he will then introduce our speakers for today. Professor Kumar.
Very good evening to all, and thank you very much, Dr. Vinita Sharanji. And at the outset, I would like to thank the GAPIO for giving me this opportunity. Basically, I am a trauma surgeon and I always look for the opportunity to participate any program which is related to trauma. So I'm very happy that GAPIO is organizing this webinar on trauma radiology. And I think without wasting much time, let me start with the introduction of the speakers, and then we will take the questions and discuss about the talks, if it is okay with you. So let me have the pleasure to invite the first speaker. He's a dear friend of mine, Dr. Atin. He needs no introduction, and it's a pleasure to introduce him. He's a professor of radiology at AIIMS, New Delhi. He has published more than 276 articles in the peer-reviewed journals, more than 33 chapters. He has been invited to various conferences, both national and international. He has delivered more than 220 guest lectures, including orations. His special interest is in trauma radiology, interventional radiology, pediatric neuroradiology, and he has received several awards in the field of radiology. I can only say that we are very fortunate to have him with us in the trauma center. And as a trauma surgeon, I can say that 50% of our work is taken care of by our radiologists in the trauma center. And that work includes the therapeutic radiology. I'm not talking about the diagnostic radiology. So we are very fortunate to have Dr. Atin and Dr. Shiva with us in the trauma center. So let me invite Dr. Atin first, and then subsequently I will introduce the next speaker. Dr. Atin, please.
Thank you so much, dear Dr. Subodh. And thank you so much, Dr. Vinita, Dr. Jairam, and the entire GAPIO team for giving me this opportunity to be amongst all of you and speak about something which is dear to my heart as well. We've been, Professor Subodh and me, we've actually been in trauma center for now last 19 years. We've established it and working, and this field is very dear to us. So we work in tandem with the entire team. And let me just directly go to my talk, which I'll be speaking today on. Okay, this is fine. Imaging in chest trauma. And I will be speaking about covering almost all aspects of chest trauma, but I will not be covering vascular injuries and cardiac injuries of chest trauma, which will be covered by my esteemed next speaker, Dr. Asutosh, after this. So in the next 20 minutes or so, which have been allotted to me, I'll try and show you certain examples, how we recognize these injuries, how we as a radiologist play a role in the management of these injuries, and how we work in a team to with our surgeons as well as our critical care colleagues to manage these patients. So imaging in thoracic trauma begins, the radiographic evaluation begins right after the initial trauma team assessment. In our center, it is quite standardized, protocolized. Patient is triaged in a green area, yellow area, or red area. So those patients who require an initial assessment and evaluation and are taken in the ER in the yellow area or in the red area, while their primary initial resuscitation, initial evaluation and resuscitation are being done, the radiograph comes as a adjunct to the primary survey itself. So the imaging for chest trauma is done right there. If the patient is in the red area, the assessment is done right at the bedside by a portable X-ray machine. Or if the patient is walking and is stabilized after the initial trauma, is sent to the radiography room, which is in the ER itself to get the chest X-ray done. So initial study is usually the supine chest radiograph as well as a fast ultrasound examination. FAST here stands for focused assessment with sonography in trauma. This examination is actually done for assessment and detection of free fluid in the cavities in the body. It was initially used and predominantly done for picking up peritoneal free fluid. However, it has been now extended up to include and cover the chest, and we call it an extended fast examination to look for fluid in the pleural cavity, to look for fluid in the pericardial cavity, as well as to detect pneumothorax. All this can be detected very well because it is pretty sensitive on a ultrasound fast examination also. So a combination of these two usually helps the ER team or the trauma surgeon to take a call that how much are we suspecting a chest injury in this particular patient. The clinical scenario, the clinical evaluation, as well as the findings of radiograph and fast examination, then decides whether this patient requires a further definitive investigation, which is the contrast enhanced CT scan or not. So those patients who are stabilized after this and are suspected to have a decent amount of chest injury are subjected to a chest CT in our center, which is the standardized mode of evaluation for these patients. And CT is the gold standard and the best modality to detect all sorts of chest injuries, right from vascular injuries to lung parenchymal injuries to airway injuries to pleural injuries to diaphragmatic injuries, as well as the chest wall injuries, including the spine, the clavicles, as well as the rib cage. So that's what we play a role in terms of imaging these patients. Once we've imaged these patients, and I'll talk predominantly about the chest CT today, we see and evaluate these examinations in a standard protocolized manner, in a systematic manner. So first of all, we want to look at the lung parenchymal injuries. Amongst the lung parenchymal injuries, the major four things which we see in the patients in the setting of chest trauma are contusions, lacerations, aspiration pneumonitis changes, or atelectatic changes. These are the four most common findings which we see in chest trauma patients. So how a contusion looks like on a chest X-ray or a CT. Contusion, as we know, is basically bleed in the alveoli. It is secondary to a direct blunt trauma, could be secondary to a penetrating trauma also. What you see is basically airspace alveolar opacities in the chest. On the chest radiograph also, you can see a generalized alveolar opacity, or on the CT, you could see generalized hyperdensities, which are like alveolar opacities in any part of the lung. It is predominantly seen usually at the periphery, more towards just beneath the subcostal or just beneath the rib parenchyma. It is usually not exactly limited to the fissure. It can cross fissures depending upon which part of the lung bears the impact. And you see them as fluffy opacities or sometimes ground glass opacities or sometimes areas like consolidation through which the vessels can run through. In the setting of trauma, when the patient has trauma, all this actually represents lung contusion. This is often associated with the overlying rib fracture. However, that is not always the necessity, especially in children. There may not be rib fractures, but there may be underlying lung contusion. But in adults, it is often associated with rib fractures. As you can see in this particular case, there are overlying rib fractures and underlying contusion. Since it is a bleed, in the natural evolution, the contusion usually takes a small duration to evolve, and actually it starts to disappear by 24 to 48 hours. And by 3 to 5 days, usually the bleed or the contusions usually disappear, right? In contrast, a laceration is basically a shearing injury of the lung. It is a tear in the lung parenchyma. So the lung parenchyma tears along the interstices, and once a tear occurs, there is a cavity which forms there. So the cavity gets filled up with air, which leaks from the alveoli, or there may be hemorrhage in the cavity. So if you see a local area of air containing area within the lung parenchyma, or which has got some amount of bleed also. So there may be air, there may be blood, air, blood level, air fluid level, and may be associated with the surrounding contusion. These are the classical appearances of a lung laceration. This is a shear type of injury. Sometimes a lung laceration is seen at the periphery. One of the common locations is at close to the vertebral margins, and these can be longitudinally extensive also, like this is a large area of tear or a laceration in the lung parenchyma. In this case, this is a laceration here. Again, this needs to be seen and diagnosed, because then this is the marker for a severe form of a lung injury. Having said that, this does not usually require any active management and needs to be followed up. Only it can lead to, if it is extensive lung tear, it may lead to problems in oxygen saturation, breathing problems, but otherwise not actively managed in terms of operative intervention. Other common finding which we see is aspiration pneumonitis. We all know what aspiration pneumonitis looks like. It's more like a train butt type of a pattern, which is seen more in the dependent parts of the lung and the basal segments, especially in the lower lobes or more on the right side. Even if it is seen in the upper lobe, it is seen in the dependent segments. These are classical dependent opacities. If they start getting coalesce, they form more like a consolidation pattern, but this is recognized more by the specific areas of the lung which is involved. This can be seen in the setting when the patient is not in full sensorium. So his GCS is low, then there could be aspiration, or there could be a severe maxillofacial injuries. At the time, there could have been aspiration of blood also by the patient. So therefore, you can see them in these particular areas. And then there could be atelectasis. Atelectasis is nothing but a collapse of the lung parenchyma. So it is basically a collapse. This is also commonly seen more in the dependent parts of the lung, especially adjacent to a significant amount of pleural blood, so hemothorax, and it is because of a passive collapse of the lung parenchyma. So it is often seen some of the lung parts are not exactly expanding and they are atelectatic. So they are often seen with adjacent hemothorax. Okay, so these were the kind of the lung injuries which we commonly see. Coming to pleural injuries, we all know when there is a pleural injury, there could be either pleural fluid. In the setting of the trauma, we classify pleural fluid as hemothorax unless proven otherwise. So whenever we see a fluid, we label it as hemothorax. We don't call it pleural effusion, right? And it is seen in up to 15 to 40% of all chest trauma patients. It is basically, when I'm talking about pneumothorax, it is air in the pleural cavity, and it occurs especially due to alveolar rupture along with the associated visceral pleural tear. So the air from the alveoli leaks out and leaks into the pleural cavity. It can also secondarily sometimes occur due to an external pressure of a rib fracture, which is penetrating into the lung and can lead to a pneumothorax. Again, as I told earlier, chest X-ray or an extended fast ultrasound is the first modality to detect pneumothorax. Having said that, it should be remembered, especially for the radiologist point of view, that what we are tuned to looking at a pneumothorax in our routine settings is not what we see in the chest trauma patients. In an erect X-ray, pneumothorax, we all know, are easy to describe because you are seeing this as a air opacity at the lung apices with the lung margin seen beneath it with no lung margins in that area, because the air goes to the most non-dependent part, which is the apex. That is easy to see. But most often, our patients who have a significant chest injury undergo a chest X-ray, which is done in the supine position. So that those signs of the classical pneumothorax which have been described are not evident here. What we see on a supine X-ray is a zone of a radiolucency, which is more homogeneous because the air collects in the just beneath the anterior chest wall. That is the most non-dependent part. It leads to a generalized lucency in one part of the hemithorax. So if there is a differential density of the two hemithoraces, one appears more lucent, you have to suspect that there could be a pneumothorax here. Especially in the lower parts and in the medial aspects, you can also see a sharp margin of the diaphragm. This also is a sign that there is an extra alveolar air which is present here, which is outlining the diaphragmatic contour. Sometimes you see a deep sulcus sign. That is also a sign for a pneumothorax. And all these signs together on a supine X-ray helps us to diagnose pneumothorax. As you could see, this is a chest CT which has been done. In our center, the trauma surgery team is well organized to detect pneumothorax either clinically or by auscultation or by percussion, aided, of course, by radiological e-fast examination and a chest X-ray. And first and foremost, ICD is placed if there is a significant pneumothorax. Placing of a ICD is a part of the primary resuscitation and management of the patient. Only once the ICD is in place, usually this patient is sent for CT. So when the patient comes to us for CT, when he's stabilized, if we see a pneumothorax, we more often always have a chest tube ICD in situ in that particular patient. Having said that, CT is very much more sensitive in detecting a pneumothorax. This was some form of a moderate pneumothorax, which we are seeing here. And as you could now see, there are extensive areas of contusion in this particular patient also. But what is important is sometimes the chest CT picks up a very thin amount of pneumothorax, which may not have been clinically detected or may not have been picked up in the initial chest X-ray, or even if it was picked up, the surgeons may have decided not to put a chest tube in that particular patient. If you detect this, which was not detected earlier, it is known as an occult pneumothorax. Is there any significance of occult pneumothorax? Yes, as a radiologist, we need to describe this and inform the surgeons that there is a pneumothorax. In isolation, this may not be significant, but may require some intervention, especially if this pneumothorax is getting symptomatic, or if the pneumothorax occupies more than 20% of the entire lung volume. So if the pleural volume occupies more than 20%, or the patient is either on a endotracheal tube with a positive pressure ventilation or requires some form of operative intervention because of any other associated extremity injury or any other injury. In those cases, this pneumothorax can significantly increase. So this needs to be communicated, and maybe they would like to put in a ICD in situ. So even in a occult pneumothorax, which was subsequently detected. There could be scenarios, as I've told earlier, sometimes the pneumothorax occurs due to a rib fracture jutting in. So as we can see, this is also we need to be described in the radiology CT examination. So a rib fractures, which are leading into a puncture into the lung parenchyma, causing a pneumothorax. And this also is leaking to a extensive subcutaneous emphysema. Sometimes there could be chest wall injuries itself, and it could turn out to be an open pneumothorax. As you can see, we make extensive good quality virtual 3D images, which clearly show the amount of chest wall injury also, which gives a very good perspective to the surgeons to manage these patients. Pneumothorax, a special scenario is a tension pneumothorax. This also ideally should not happen when the patient is being subjected or sent to the CT scan. More often than not, if it is present, it is diagnosed clinically or radiologically itself in the ED itself, and this is taken care of by putting in the ICD. If it is emergency tension pneumothorax, a needle thoracostomy followed by a definitive treatment of ICD insertion, which is done. If the patient reaches a CT scan and if you still find a significant amount of pneumothorax, this is called as a tension pneumothorax. How do you differentiate it on radiology from a normal pneumothorax? Although there are clinical signs which should pick it up based on a raised IGV pressure also, and a patient having significant amount of breathing issues. But on radiology, if the underlying lung is showing a significant collapse, if there is widening of the intercostal spaces, if the diaphragm is just pushed down and sometimes even inverted, those are signs, and with a significant mediastinal shift, those are signs that there is a tension pneumothorax. Another example, see the ICD was already in C2, but in spite of that, the lung was significantly collapsed, the pleural cavity pneumothorax was significantly high, and the diaphragm was getting inverted. So this was communicated urgently to the surgeon that there is a tension pneumothorax which was developing. This does not need to be put in the report, written report. Of course, this needs to be put, but it is not that someone will see this report. This needs to be communicated on phone itself as an emergency, and if possible, a needle thoracostomy should be done. In this case, there was ICD already in situ, so that means that another ICD is required to drain this pneumothorax if this ICD was not adequately draining it. Hemothorax, on the other hand, gives you a generalized haziness on one part of the. Again, erect is easy. You can see a S-shaped curve going along the lateral walls. But it is difficult to detect this on a supine, again, because there is a generalized haziness that we detect. Of course, it is easy to detect on a CT where you could see a pleural fluid. Again, I've told you a pleural fluid in this setting means hemothorax. We can take the help of measuring the density, but we typically do not measure densities to try and differentiate a sympathetic pleural effusion from a hemothorax. As it is, if it is significant, usually ICD is put in this, and what drains from the ICD typically defines whether it is a hemothorax or just a serous amount of fluid which is seen. What as a radiological, what we need to describe is, if sometimes we see a cause of hemothorax, sometimes we do see active contrast extravasation. So you see there is vascular contrast density which is leaking in, and there is a high density hemothorax which is seen and it is getting clotted. This can be communicated that there is active bleeding going on. So this may require a more aggressive forms of drainage to prevent a significant amount of fibrosis which may develop subsequently, or the patient may go into shock if this is not treated. Coming to pneumomediastinum, as the name suggests, pneumomediastinum is air going into the mediastinal cavity. The source of air going into the mediastinum more often than not is a alveolar rupture. Alveolar rupture occurs, the air leaks into the interstitium with constant breathing in, breathing out. The air tracks along the interstitium and with a enters into the mediastinum, leads on to a pneumomediastinum. This is known as a Maclean effect. So how do you see it? On a chest X-ray, you see air outlining the mediastinal margins, like you see a lucency outlining the left heart border here, some lucency along the right heart border here. This, you describe this as a pneumomediastinum. Sometimes you may think this can be pneumopericardium rather than pneumomediastinum because this is outlining the heart. But what helps to differentiate it, if you see this air going above the level of aortic root, and of course, if done a CT, you could see this air tracking above the level of aortic root. That means it is pneumomediastinum because the pericardial lining stops at the level of aortic root and does not extend up. And this you can see extensive pneumomediastinum going up in the superior mediastinum as well as subcutaneous emphysema as well as air along this heart. So this is pneumomediastinum. Mediastinum is not a true space. So air, once it comes, it is going in the interstices. So you will always see some amount of shaggy cobweb type of appearance or some form of septae in this. This is how a pneumomediastinum looks like. On a chest X-ray, again, this is another example. There is extensive subcutaneous emphysema as well as air outlining, sharp outlining the lateral heart border as well as the lower part of the thorax. And once we do a CT, we can clearly see pneumothorax. But once you, sorry, a pneumomediastinum, but it is often associated with pneumothorax also. This is usually associated with a pneumothorax also. But once you see this, most often it comes from the alveolar rupture in the lung, but as a duty of the radiologist, it is to look for and detect if there is any tracheobronchial injury or not, which can also lead to pneumomediastinum. So this was an extensive pneumomediastinum case. As you can see, there is extensive pneumomediastinum in this particular, extensive subcutaneous emphysema. This needs to be differentiated from a pneumopericardium. I have told you pneumopericardium would look like this, but would get limited to just to the pericardial margin. It will not extend upward superior to the aortic root. So this is our pneumopericardium, and pneumopericardium will be sharp in margin. It is a true space. Pericardial space is a true space. This is more problematic because a extensive pneumopericardium, if it is continuously leaking, it can lead to a cardiac tamponade. That is what is required to be seen. More often than not, this also usually resolves over a time, but you need to be aware of this. So you need to look for tracheobronchial injury also if there is extensive pneumomediastinum. More often than not, it is caused from a penetrating injury, much more common than blunt injury or iatrogenic injury. Penetrating, of course, can be more in the exposed region, especially in the upper larynx or upper trachea. But a blunt trauma leads to airway injury more at the fixed points, which is close to the carina. So I'll show you some examples. You will be missing it unless you are specifically looking for it at multiplanar reconstruction. So you see there is extensive surgical emphysema in this particular case. There is extensive emphysema in the neck spaces. But when we saw clearly, there was a tear in the posterior wall of the trachea, right? And as we could see on the multiplanar reconstructions, this is a tracheal injury, posterior tracheal injury. Another example, in this case, there is extensive pneumomediastinum, but when we were searching carefully and trying to rule out a tracheobronchial injury, we could see an intimal flap in the trachea, distal trachea, just close it to the level of the carina. This is the most common location where a blunt airway injury occurs. Once you see this, you can tell that this probably is the cause of the leaking. They can do actually a bronchoscopy to confirm this, and sometimes can even inflate a balloon here so that there is a adequate healing of this intimal flap. Sometimes you could see a complete bronchial injury. In this case, there is a complete bronchus cutoff, and there is a bronchial rupture here. This is leading on to a complete collapse of the lung here, and this lung is not going to expand because there is a complete. This was confirmed on a bronchoscopic examination. This also the radiologist will actually make a diagnosis. This we need to pick up, and these are the MINEP images, good multiplanar images which can help us to diagnose this. There can be sometimes esophageal injury also, which we need to detect because this leads to a significant morbidity. We know that the etiology more common is iatrogenic or toxic ingestions, but it can still occur in blunt trauma also. This needs to be thought of when we are suspecting clinically. This is when the patient is unable to tolerate fluid, or there is extensive pleural effusion, or if a ICD is put and there is a leak of the chylous fluid from the ICD or food particles, then you are thinking in terms of esophageal injury. If we are suspecting this, we need to give a oral positive contrast, and a leak of oral positive contrast confirms a esophageal injury. Another example, extensive subcutaneous emphysema, but when we saw at the lower level, there was a large amount of air as well as fluid close to the esophagus. Oral contrast was given, and we saw there was a complete rupture of esophagus at the lower margin in this particular case. Lastly, one important thing is to look for a diaphragmatic injury. This is one injury which would actually definitely require a surgical repair, besides aortic injuries or vascular injuries, which will be covered later on in the other talk by the speaker. But this is also what we need to look for. Diaphragmatic injuries, left is much more common than the right. We know the signs which are seen on the chest X-ray. You may see abdominal contents herniating up into the chest cavity, which is best easily identified by loss of diaphragmatic contour or by looking at bowel shadows appearing in the chest. However, CT is the diagnostic modality. Let's look at some examples. In this chest X-ray, we look what looks like a raised left hemidiaphragmatic contour. However, we know now that this is not exactly the diaphragmatic contour. It is just appearing because this is actually the stomach wall which has gone up into the thorax. Another example, in this particular case, there is extensive herniation of bowel opacities as well as stomach opacities in the what appears in the chest, but the definitive investigation is a CT scan. So once you do a CT scan, you can see like a chest in the stomach actually herniating up. There's a Ryle's tube, nasogastric tube in the stomach, and the tip of the Ryle's tube is lying way into the chest. So these are the short signs of a diaphragmatic injury. But the definitive sign of diaphragmatic injury is to look for a tear in the diaphragm. This is where a CT multiplanar reconstruction helps. You do a corneal image and you can see a free edge of the diaphragm. So you are sure that this is not eventration, this is not diaphragmatic palsy, this is stomach herniating up because there is a big defect in the diaphragmatic contour. And where there is a defect, there is a constriction of the abdominal contents herniating up. This is known as a collar sign. This also is a sign that there is a diaphragmatic defect. See, this is the free diaphragmatic defect here, free diaphragmatic defect here. Between these two diaphragmatic free defects, the abdominal organs are herniating and there is a constriction here. So these are the collar signs. This is the free diaphragmatic defect and the stomach is lying herniating. And as we can see, the nasogastric tube going up, this is diaphragmatic injury. Most common on the left, but often seen on the right also. This is seen because of a focal diaphragmatic liver contour abnormality. So this is also a sign for a diaphragmatic tear. Once we tell them that to our thoracic surgeons, they like to operate these patients because this will definitely require a definitive surgery. But these are easy to pick because there is a herniation which has already occurred. But sometimes we have a definitive diaphragmatic injury. As we can see in this particular case, there is a diaphragmatic injury, but there is no herniation which have occurred. So the role of radiologist is to pick up these subtle injuries also. Our surgeons would like to go in and repair this even if there is no herniation rather than leaving it for a follow-up, because then there may be subsequent hernia which may occur over a period of months, because these injuries definitely require a repair and we need to pick up these. This can be best picked up by doing a corneal and sagittal reconstructions. Another example, I'm showing you this because this changes the management. This requires a definitive operative repair, especially if it is on the free edge of the diaphragm and especially on the left half of the diaphragm. Last section, just a couple of minutes, is about a penetrating injury.
Then we can wind up, right?
Just 2
Yeah.
minutes, sir. Last I'm winding up. A penetrating injury, we need to look at the trajectory. So this is we make images, and this is we tell that what all is the trajectory of the injury in the penetrating wound, and especially if it is the shrapnel or the culprit is in situ, we tell what are the injuries, we make them according to the pattern. This helps the surgeon to look at it and plan their surgery. Sometimes it is bullets or shrapnels, we tell them localize them. It is in the pericardial cavity in this particular case, or it is in the heart in this particular case. And last but not the least, we look at the chest wall injuries also. We diagnose flail segments, which are sometimes clinically evident, but we tell the roadmap for the surgeons to operate. We look at the sternal injuries. We look at the scapular injuries, clavicle injuries, and last but not the least, we look at the spinal injuries also. And we also look at the tubes and the lines which have been put in. So if our ICT is not put rightly, in this case, it was injuring the lung parenchyma. This also needs to be communicated. This needs to be removed and a good ICT put. There could be some bizarre examples of ICT going in two in. This needs to be example, and also the position of the endotracheal tube. In this case, the endotracheal tube was going into the right main bronchus. This was leading on to a collapse of the left lung. This was communicated. The endotracheal tube was pulled out, and within few hours, the left lung completely opened up. So this all management changing decisions are also important part of the radiological reporting. So I like to conclude here by saying chest X-ray is the first look imaging modality, has a role in detecting life-threatening conditions, but it is the multi-slice CT which is the modality of choice for looking at all of these injuries. And communicate and work in team with your emergency physicians team, especially the trauma surgeons, to overall manage these patients. Thank you so much for this.
Thank you, Dr. Atin, for an excellent and very extensive talk on the trauma radiology in chest trauma patients. So we will have the discussion at the end of the second talk. It's a pleasure to introduce the next speaker, Dr. Asutosh Sahu. He's currently is a fellow of emergency and trauma and acute care radiology at the University of Toronto. Dr. Sahu pursued advanced training in neuroimaging at King's College London under prestigious Commonwealth scholarship. Now he'll be joining the Boston Children's Hospital next year, Harvard Medical School. It's a very prestigious medical school in the United States for a fellowship in pediatric radiology. And following this, he'll be assistant professor in the Department of Radiology at the University of Michigan Medical School, where he'll be working both in pediatric and cardiothoracic imaging. Dr. Sahu's clinical expertise further strengthened by the robust research portfolio, several peer-reviewed publications, and numerous conference presentations. Over to you, Dr. Sahu.
Thank you, Professor Subodh Kumar. It is wonderful to be here today and presenting the talk in front of the wide audience. And I take the opportunity to thank the GAPIO team for allowing me to present on this prestigious platform. So I'm just trying to share my screen, and we will get started right away. Okay. So I will be talking about the cardiac and vascular aspects of the trauma. Dr. Atin Kumar wonderfully presented on the pulmonary, the parenchymal and lung injuries, and this will be complement to the chest trauma. So starting right away, I have nothing to disclose. So I will just give a brief background of the trauma. That the trauma can be either penetrating or can be blunt. So so among the penetrating trauma, the gunshots and the stab wounds count for the majority of the trauma, whereas in the blunt trauma, it can be mostly the motor vehicle accidents or falls we see as a blunt trauma. So as we discussed, chest X-ray remains the most crucial for excluding all the kinds of life-threatening injuries, as we can exclude the tension pneumothorax, hemothorax, widened mediastinum, mediastinal hematoma. And as we also discussed, the FAST remains a rapid bedside maneuver, bedside imaging modality, which has no ionizing radiation, and it has a good sensitivity for detecting the free air on pneumothorax, while the CT remains the gold standard for our trauma. So we always should have a meticulous approach while evaluating the trauma. We always should start like when we start with evaluating the great vessels, followed by mediastinum, esophagus, heart, airways, lung parenchyma, pleura, and chest wall, and the diaphragm. So we should always have a meticulous approach so that we don't miss out any kind of lung injuries or any other injuries. So today we will be discussing this briefly, what we will be discussing today on the cardiovascular imaging. So we will discuss about the aortic dissections, pseudoaneurysms, minor aortic injuries, internal flaps, tears, hemopericardium, myocardial laceration, and we will also see some hemo and pneumopericardium. So coming to the first, the traumatic aortic injuries. The traumatic aortic injuries can be like the chest X-rays are very sensitive, like to exclude, like the negative predictive value is 98%, whereas the positive predictive value is only 15%. But we see there is a very important finding, like we always look for in the chest X-rays, the mediastinal widening, the right paratracheal density, the loss of aortic arch definition, apical cap, the tracheal deviation, and there are certain direct and indirect CT signs we should also look for, like pseudoaneurysm, the internal flap, the abrupt changes in the caliber, contrast extravasation, and there are certain indirect signs, and one of the most important indirect sign is periaortic hematoma, which gives us a definite heads up about there could be a injury to the vessel. So coming to the classification of the traumatic aortic injuries, so this can be a small intimal tear, this can be a hematoma, this can be a pseudoaneurysm or a rupture. So accordingly, this is graded. So coming to the distribution of the aortic injuries, so we always see the most common site of the aortic injuries is the proximal isthmic segment, because that is where the tension of the arch and the descending aorta is the maximum. So this is the site which has a highest chance of getting injured. So we will go through certain number of cases to see what kind of like various imaging modalities, how it looks in the chest X-ray. So this is a patient who came to the trauma, and we see clearly a mediastinal widening. We see also there is also a left apical cap. We see the left apical cap, the mediastinal widening, and right paratracheal density. So when we do a CT scan, we clearly see this the extensive mediastinal hematoma, and there is a pseudoaneurysm formation and also a intimal tear. So coming to the next case, so this is a high-speed motor vehicle accident, which as we can see that there is a layering of the left pleural effusion on this side and a large left apical cap. So this suggests that there could be a mediastinal hematoma, and when we go for the CT, we see a pseudoaneurysm here clearly, and there is a mediastinal hematoma, and we also clearly see the pseudoaneurysm on the multiplanar reconstruct. This is another patient came with the motor vehicle accident. So this is initial the chest X-ray, which looks apparently normal, except there is an absence of the AP window concavity. So this should be concave, but here in this case it is convex. So it was initially read as normal, but subsequently the patient underwent a CT scan, and we could find the mediastinal aortic injury, and mediastinal hematoma is also present in this patient. So this is a very important case, like it came to our ER, and when we did the CT, we can clearly see a pseudoaneurysm here, and there is also a good amount of mediastinal hematoma here. And on the recon images, we clearly see the pseudoaneurysm, and there is pneumomediastinum and hemomediastinum. And as we see here, there is a small amount of pneumomediastinum here. And this was subsequently repaired by the trauma surgeons, by the interventional people, and then this got repaired. This is another case of 40-year female post-motor vehicle crash. So this is a minor aortic injury because we see an irregular outline of the aorta and the intimal flap. So, and there's just a small outbouching here, but there is a significant amount of periaortic hematoma here. So this, like in certain cases, the irregular outline, this could be a ductus bump, which is again a normal variant. But in this case, the presence of the periaortic hematoma, this gives us a clue that this is most likely a aortic injury rather than a normal anatomic variant. Again, this is another similar case. Again, we see a small minor aortic injury and small linear wall adherent defect, but there is no surrounding hematoma. Yeah. Again, this is a similar case, minimal aortic injury, and most of the time, these cases do not require any intervention because maybe in a couple of weeks they resolve on their own, but they just need a follow-up CT to make sure that they resolve or not. This is a case of ductus bump, which I wanted to show you. This is the ductus bump, which has a smooth obtuse margin with the aorta, and this is a normal variant. And this is like in the setting of trauma when it can be confusing, but when we see the angle of the bump, if it is acute, then this is most likely it is a traumatic pseudoaneurysm. Rather than here in the ductus bump, the margin is usually obtuse margin. So next, this is another case of motor vehicle accident. So we can see clearly the widening of mediastinum and increased right paratracheal density. So when we did the CT, there is mediastinal hematoma, of course, but we don't see the aorta was clearly normal. So this is a case of a spinal burst fracture, which led to the mediastinal hematoma rather than the aorta. So, and this is another case of mediastinal hematoma, but we see clearly that there is a hemorrhage in the anterior mediastinum. However, the aorta was clearly normal, but there was a tear in the subclavian artery, and this was the reason of the blood in the mediastinum. And we can also see sometimes the azygous vein tear. This can also lead to the mediastinal hematoma, and this is quite rare. Okay, this is an interesting case. Like the 83-year-old male came to our ER following a fall from the stairs, and when we did the CT, we saw there is clearly a descending thoracic aortic dissection, and here the teaching point is like the calcification. This is the true lumen side of the flap, and this is the false lumen side of the flap. And when we clearly see the intercostal artery is draining, arising from the false lumen side of the flap. So here the dissection was likely the cause of the fall rather than the traumatic aortic injury that resulting from the fall. So the patient first had the dissection and it led to the fall rather than the other way. This is a very interesting case of 30-year-old male following a stab wound. So this, we can clearly see the entry site as Dr. Atin Kumar showed us a case of a stab wound. So this is a stab wound showing a myocardial laceration. So here is the trajectory of the entry site of the stab wound. And we clearly see a myocardial laceration, but we don't have any pericardial hematoma in this case. So maybe the stab wounds, the stabbing was so fine, like it was so fast in such a small time that it just punctured the myocardium, lacerated, but there was no hematoma. So here the most important point is the trajectory evaluation is very important in the penetrating injuries, and hemopericardium may not need to be present in cases of injury. And when we really tried to convince the trauma surgeon to open this patient, and on the OR, there was definitely a tear injury here in the myocardium. This is another case of a female, again, showing the stabbing. So here we see a small amount of fat stranding, and we see a good amount of pericardial effusion or hemopericardium here. Also, we see a small diaphragmatic rupture here. And again, here we see some fluid and the pericardial hematoma. Now coming to it, this is a different case. So when do we suspect cardiac contusions? So this is this case showing sternal comminuted fracture. So most likely the sternal comminuted fractures are most of the time associated with the cardiac injuries. So the patient had elevated troponin levels, and this was suspicious for the cardiac contusion injuries. But this sternal fracture, this is one of the indirect signs of a cardiac contusion. Additionally, we also see some breast hematoma. This was most likely from the right internal mammary artery bleed. And also we see some mediastinal hematoma, which was extending to the origins of the aorta and the pulmonary trunk. So again, this is suspicious for, again, the cardiac injuries. And here is a case of cardiac tamponade. So when we suspect when there is pericardial hematoma, because the pericardial cavity is a fixed space, it cannot expand much. So when there is blood accumulating in the pericardial cavity, so there is a chance of developing cardiac tamponade. And when there is cardiac tamponade, we will see the inversion of the right atrial wall, as we can clearly see here. And due to the heart not able to receive blood, there will be distension of the superior vena cava. You can see here. Now we will go through certain pitfalls. What are some technical pitfalls, some anatomical pitfalls, and some pathological pitfalls. And so this is an important imaging pitfall, like the motion artifact. So the motion artifact can sometimes look like a aortic injury, but most of the time we need to repeat the CT scan with a cardiac ECG gating, so the motion artifact can be resolved. And again, this is another one showing the streak artifact. The streak artifact can also resemble like small aortic injuries, the minor aortic injury or some trauma. Again, we need to follow up these cases. So this is again showing the motion artifact. See here, the motion artifact showing both on the aorta and the pulmonary trunk. But when we did the repeated scan with the ECG gating, the motion artifact resolved. So this is another technical pitfall of the imaging. So here we see in the arterial phase, we see a small filling defect here, and which is again suspicious for some minor aortic injury. However, this was actually a mixing of the blood in the arterial phase. And when the patient had a portal venous phase imaging, this was not there. So this was mostly a mixing artifact. Again, as I already discussed about the ductus diverticulum, which can be anatomical pitfall, and also the aortic spindle. Sometimes the aortic spindle also can we can see in certain trauma cases and can be confusing. So just to know about this. And sometimes the ductus bump can be atypical, unlike the previous one where it is clearly smooth ductus diverticulum. So sometimes it can be atypical, and we see here this looks like apparently an intimal flap, but there is no periaortic hematoma here. And however, there is mediastinal hematoma, which was from the rib fractures. So again, when we did the reformers, we can see small outpouching, and the obtuse angle was there superiorly, and the acute angle was there in the inferior aspect. However, when angiogram was done, this turned out to be a ductus bump and not any injury. And this is one pathological pitfall. So sometimes the patient can have non-calcified atherosclerotic plaques in the region of the descending aorta, and this can be sometimes confusing. In the setting of a trauma, like especially when we don't have any follow-up imaging or any prior imaging of the patient, and the patient is coming for the first time, and we just see a non-calcified atherosclerotic plaque. So that can be quite confusing, and this can be a pitfall for aortic injury. So what are the most important things? Like this is the most important slide of the talk. Like these things can get missed on the chest X-ray, like cardiac injuries, the aortic injuries, the esophageal, tracheobronchial injuries, and the most lethal injuries in the chest trauma are heart injuries, the cardiac, aortic, and the blast injuries, and the tracheobronchial and the diaphragmatic injuries. These are the most lethal injuries, and these can be potentially missed, like the heart injuries, esophageal, the diaphragmatic injuries. So the main take-home points for this presentation is the clinical presentation can sometimes be misleading, and therefore we should always have a high index of suspicion when evaluating the cases of lung trauma. And chest X-ray is very important to exclude any kind of life-threatening conditions. However, the CT is the modality of choice due to obviously for the higher sensitivity in most cases. And we should always have a systematic approach so that we do not miss any injury. We should always, just I showed you, we should always have a systematic approach of evaluating the aorta, the diaphragm, the lungs. So we should always go in a systematic manner. And there are certain specific injuries that are associated with, just like I showed you, the sternal fractures, they are associated with the cardiac contusions. Similarly, there can be rib fractures that are more likely associated with the pneumothorax, and sometimes upper rib fractures, they can be associated with the subclavian or the axillary vessel injuries. So we should always keep looking for the kind of trauma it can be associated with. So that's all. Thank you for your attention.
Thank you very much, Dr. Sahu, and very extensive and beautiful talk. So I have to make a couple of comments before we take the questions and discuss this topic further. So stress trauma is a very, very important topic in a trauma setting, because around 1/3 of the patients who are admitted following trauma, they have some kind of chest injury, either isolated or as a part of the polytrauma. This is one. And all the residents who are attending this webinar, they have to understand that trauma alone is responsible for more than 25% of trauma-related mortality. So you can understand how important the chest trauma is. But the good thing about the chest trauma is that if you have a clinical suspicion of chest injuries, all these injuries can be managed by simple interventions within the capability of a resident doctor who is managing these patients in the ER. By simple ER procedures like needle thoracostomy or ICD insertion, or sometimes the endotracheal intubations. So 90% of these patients can be saved with simple ER procedures. As opposed to the Western, we do see in India more blunt trauma than penetrating injuries. More than 90% of them have blunt injuries as opposed to the US or other part of the Western world. The most important message I want to give here is that, and especially to the residents, you should make a clinico-radiological diagnosis. Do not interpret the X-rays or CT scan in isolation. And this holds true both for clinicians as well as the radiologists. So I think Dr. Sahu, he ended his talk by saying that keep looking. And that is the most important message. If your patient is not improving it, and if you have a doubt, you must go and discuss with your radiologist, or radiologist should call. Dr. Atin said in his talk that you should write in the report, but at the same time, there are some situations that you should actually pick up your phone and call your colleague that, look, there is a problem in this patient. So clinical radiological diagnosis is the key to success to make a final diagnosis and further management of these patients. We'll discuss further about this. Dr. Tin, there is one question for you in the chat box. I can see that how to differentiate between the pneumothorax or hemothorax on a supine chest X-ray, which you have explained. But again, I will request you to explain this once more time.
Right, sir. So either a pneumothorax or a hemothorax would lead to a differential opacities on a chest X-ray between the two sides of the hemothorax. Of course, we can clearly logically understand a pneumothorax will give rise to a increased lucency, so the increased black areas on that part side of the lung, whereas a hemothorax will lead to a generalized haziness. As told earlier, on a supine film, these are generalized opacities rather than free margins, which we are used to seeing on an erect chest X-ray. Erect chest X-ray is the standard chest X-ray for any patient. 90% of the 80% of the chest X-rays are done erect, right? So in this scenario, the pneumothorax or the hemothorax, if they are accumulating, will lead to some form of mediastinal shift on the contralateral side. So if you see a mediastinal shifting, mediastinum getting shifted or a diaphragm getting depressed on the side, mediastinum shifting to a contralateral side, diaphragm getting depressed on the same side, in which there is a hyperlucency, then you know that there is a pneumothorax on that side, which is leading on to shift of mediastinum contralateral and diaphragm depression on this side. And if the mediastinal shift is towards a side in which the side which appears less lucent than the other, then that means there is a hyperdense contents on the other side, which is a hemothorax. And again, as Dr. Subodh said, this is not just one radiology which we're talking about. There is a clinico-radiological correlate. Your emergency physicians or the surgeons would know just by a normal percussion or a auscultation which will tell you that there is a pneumothorax or a hemothorax. This is, of course, when you have not aided it with a E-fast ultrasound, which is also going to differentiate a pneumothorax from a hemothorax. That's how we take into account.
Thank you very much. I think Dr. Sushil Jain, he raised a hand. You want to say something?
No, that was so. Actually, I wanted Dr. Atin to sort of emphasize on the clinical radiological, because the radiolucency and radio opacity would be relative. So that's where the clinical, and that's why I specifically asked this question for the benefit of the residents.
That's right.
Not only
That's
the
right.
radiology, it has to be clinical
Yeah.
radiology. Thank you.
So, yeah. So I don't see any question in the chat box, but I want to ask from Dr. Atin first that you shared in your closing slide that the chest X-ray life-threatening condition, the tension pneumothorax. I think the message is loud and clear in your talk that the tension pneumothorax should not be diagnosed on the chest X-ray, and we should be able to diagnose it clinically. All the ER physicians should be able to diagnose tension pneumothorax clinically. And if you have a chest X-ray, we say our residents that it's most likely a postmortem X-ray. That's
pneumothorax, yeah.
Absolutely. So, Dr. Sahu, most of these patients with the aortic injury, because you discussed, they don't make it to the hospital. And I think you will agree with me that less than 10% of them, they make it to the hospital, and they are generally hemodynamically stable, because in spite of the fact that they have a aortic injury, which is contained to the mediastinum, and as you rightly said, it's the most common site is the ligament of teres near the isthmus. It's for the residents, sometimes if it is a very tricky clinical situation, the aortic injury with associated hemothorax. So that's a more for the resident. I want to make a comment that we should refrain unless there is an obvious indication of putting the chest tube, patient is on ventilator, not maintaining the saturation. If it is associated with the hemothorax, you should refrain from putting the chest tube until and unless you take care of the aortic injury. So it may dislodge some kind of hematoma. It may disturb the hematoma, and patient may start deteriorating. This is one. I want to ask you one question regarding the cardiac tamponades at times, and Dr. Atin will agree with me that at times it is difficult for us to diagnose whether it's a pericardial hematoma or it's a pericardial fat, and at times we struggle. So what your suggestion or your comments on this, that how to resolve this issue, and patient otherwise is hemodynamically stable, and we discussed the whether it's a hematoma or it's a pericardial fat pad, and we struggle a lot.
Yeah, it can be a difficulty sometimes radiologically, of course. So I would suggest doing echo, if possible, a bedside echo. That could be useful in differentiating a fluid from a fat. Otherwise, MR, cardiac MR can always be helpful. If the situation is there, if the time permits, the patient is stable and must exclude between the two conditions, then these are the two options.
Yeah. So I was actually looking for the echo, because I think I don't remember in the last 20 years we have ordered AMR for the cardiac injury at the trauma center. I don't recall any even a single case. So, but I think that's the message I want to give to the residents, that at times the cardiac tamponade, again, it's a clinical diagnosis. And if you are suspecting, especially in patient with the blunt injury, there are telltale signs. There is a external fracture, there is a pericardial effusion, which is likely the blood or hematoma. And if you are confused, and if patient is hemodynamically stable, then nothing to worry. You can go for CT scan. Still, you have a doubt, then consult your cardiologist, go for a echo, and you can resolve all these issues. So I think Dr. Vinita, if you want to discuss something, and I don't see any questions in the chat box.
Actually, initially, I would like to thank all three of you, both the Professor Kumar and Dr. Sahu, for extremely important role of clinical radiologic correlations. And I think most of the time there are reports that correlate clinically on. So having a direct association between the clinical and the radiological reports is very, very important. So thank you for that. I have a question that is probably for the future. I think there's a lot of talk about artificial intelligence. So in cardiothoracic trauma imaging or treatment, do you think that artificial intelligence will come in any role?
I think I will pass this question to Dr. Atin. He recently did a research of using the AI in chest trauma patients with regard to the refracture. Dr. Atin.
Yeah, so ma'am, AI has come a long way in picking up in especially chest X-ray, right? We know there are lots of official or commercial AI algorithms which are available to pick up findings in the chest X-ray, pneumothorax, hemothorax, lung lesions. They can all be picked up by AI. Same can be applied in trauma settings also. What we did a kind of we tried to make some algorithms in AI, or in fact a program to pick up rib fractures on a 3D model of a chest CT, not just on a chest X-ray, and pick up all fractures, define those fractures, characterize those fractures, because when we are scrolling and seeing our chest CTs, like say, because when we are scrolling axial sections, there are 12 ribs on each side and multiple zones on each one segment, which we see there are ribs cutting in at multiple segments. Picking up all those rib fractures, like labeling them, classifying them, is a tedious job for a radiologist. But ultimately, all those need to be picked up, put in the report. We're trying to make a AI-based software or algorithm by feeding in multiple chest CTs so that this part of the report is easily taken care of. Once you run it through algorithm, it will pick up and detect fifth, sixth, eighth ribs on the right side, third rib on the left side, anti-respect, single point, 2 point. This a written report comes, displaced, not displaced of these ribs, this fracture comes. We tried making, we've had some success in this, and we are working more on this in classifying this. And maybe Dr. Asutosh can tell something about aorta also or something. No?
Regarding aorta, yes, definitely AI can have a good results, but I have not had a direct first-hand experience. But we see the role of AI more in the cardiac MR aspect, like for the routine cardiac MR, that the segmentation and the volumetric analysis, that AI has taken a great role. But aorta, like there are definitely some softwares available here in our hospital, which can characterize aortic, it can pick up definitely minor aortic injuries, because obviously you don't need anything like AI to see a big aortic injury in significant here. So definitely it has a important role, and I think in the future, the more applications will come up.
Okay, thank you very much. Actually, the company for which I work, they also have a Genki, the AI software which they use for screening for tuberculosis. And the X-rays that I read for them, they also have, the AI was also able to look at all the chest tubes and their locations. So that was very interesting to note that AI actually can be used. Probably it will reduce the reporting time of the TSL, Dr. Atin said. So thank you, doctors, for your time. And I would now like to invite Dr. Sushil Jain to give our closing remark. He is the Honorary Secretary of GAPIO, and he's also the Medical